My name is Kathy Black. I am the Physician and Community Relations Manager for Rebound Orthopedics and Neurosurgery. I would like to now introduce you to our speaker tonight, Dr. Matt McGehee. Dr. McGehee is double board certified in physical medicine and rehabilitation, as well as pain medicine. Dr. McGehee has subspecialty training in the diagnosis and treatment of spine and musculoskeletal injuries. Originally from Chicago, he trained in physical medicine and rehabilitation at the University of Michigan, where he served as chief resident. He relocated to Portland to complete a pain medicine fellowship at Oregon Health and Science University, where he was trained in advanced spine interventions. Welcome, Dr. McGehee.
Thank you very much, Kathy. I hope everyone can hear me and see me well. I've been looking forward to starting these virtual seminars. This is something that is obviously new to Rebound and new to a lot of us. Getting together online is something that seems to be more the norm now than the exception. So first of all, thank you to all of you for taking time this evening to come in and listen to this educational seminar. One of the things that we all are challenged with family time and the World Series and everything else, and to take time to learn about healthcare and different opportunities potentially that may be a benefit to you is really appreciated. So from the Rebound family to your family, thank you for joining us this evening. One of the things that I wanted to just start out with you is I've been in practice in Portland and Southwest Washington for the 13 plus years now, and I've seen a lot of the changes that have happened in that span. Practice patterns change, new technologies emerge. We're always evolving in terms of things that we can offer our patients. So one of the things that we hope to do tonight is summarize some of the trends that we've seen, and then also talk about some of those emerging technologies. So without further ado, I'm going to be talking this evening on non-opioid alternatives to manage persistent pain and restore function. Pain is subjective. Well, what exactly does that mean? I wanted to lead with this simply because we're talking about pain. My pain is unique to me. Your pain is unique to you. And one of the hard things that has been talked about quite a bit in terms of pain medicine is that what defines everyone's individual pain experience? Well, there are several threads that kind of bring us all together. And that is the common experience that we have in the way that pain impacts us. Pain and function roll together, and they oftentimes overlap. And as they're overlapping, it's in these common experiences that we begin to learn about different ways which one person's experience can impact you. It impacts me as a provider and how I interact with my patients, and it impacts how you interact with, you see a loved one who has chronic pain or has a sciatica that's not getting better. If there's anything that you glean from this evening's talk, just know that you're not alone in this process. Everyone has an opportunity to learn, and you'll see the numbers are astronomical in terms of how pain is present, the prevalence of pain in the United States, and how that can be you or your neighbor or your loved one. So as you're going through this process, think about that. What does it mean to have pain? You know, the Long Baker faces there, no pain, all the way up to very severe, the crying face. The line with 0 to 10 is the VAS scale, or a visual analog scale. We can figure out where someone finds their pain, or make an X where you have pain. And then the 0 to 10 on the right side of the screen is really kind of trying to give people some context in terms of what pain experience is. But as I said before, pain is subjective. You know, someone's 5 is someone else's 2. Someone's 10 is someone else's 3. And so one of the things that as it relates to this is that through that experience, always take these ratings as relative to you. I often think about physiatry, and physical medicine rehabilitation is my medical specialty. We talk about function. And what does it mean to have true function? What are your goals? What are you trying to accomplish? That is where these pain scales come and they go. Because just as important as your numerical pain score is your function. And bringing quality to life is just as important there as well. Some of the topics we'll be discussing this evening: overview of pain in the U.S. I'm going to share some data regarding opioids. I'm going to talk a little bit about different types of pain, typical treatment options. Take some Q&A at the end, hopefully as time allows. A couple things. During the talk tonight, there'll be 2 instances where we'll have a virtual questionnaire. So at that point, you'll see a questionnaire pop up in the sidebar in the chat section. And then when that pops up, I would like you to take a minute and click the radio button that most applies to your reply. And then we'll move forward from there. So in 2012, there was a publication in the Journal of Pain that looked at data from 2010. And that was from the Medical Expenditure Panel Survey. And then this was a large set of government surveys that looked at families, individuals, medical providers, and employers. In doing so, they were able to collect enough information to make estimates on the cost and the burden of chronic pain. In 2010, it was estimated to affect 100 million Americans. Now, in 2010 dollars, annual societal cost for chronic pain is estimated. These numbers are estimates, but astronomically large: 560 to 635 billion dollars. Now, that is a result of not only medical expenses, but lost production. That exceeded the combined cost of cardiovascular disease and cancer combined. The CDC publishes weekly the Morbidity and Mortality Weekly Report. And this is a document that goes through and summarizes a lot of issues in terms of healthcare, infectious disease, or otherwise. Now, in 2016, the CDC analyzed data from the National Health Interview Survey. That data was published in 2018. They sampled 33,000 U.S. citizens over the age of 18 to get prevalence estimates for the entire nation. Their findings are interesting as well. But before we get to that, we have our first question. In the past 6 months, how often do you have pain? Would you say never, some days, most days, or every day? Over the last 6 months, how often did pain limit your life or work activities? Would you say never, some days, most days, or every day? Chronic pain was defined by the International Association for the Study of Pain as most days or every day in the past 6 months. So, impact chronic pain, it was defined as chronic pain that limited life or work activities on most days or every day during the past 6 months. Now, each of these two were integrated into that study that was conducted by the CDC. And the questions you just answered were specifically, the first one was in reference to the definition of what would be considered chronic pain. The second question was in reference to the definition of what would be considered high impact chronic pain. And the data is a little bit different on each of these as you look at how they stand out. Estimated 20.4% of U.S. adults had chronic pain, about 50 million. Now, that goes to what I was saying at the beginning of the talk. You're looking at astronomical numbers. 20.4% of U.S. adults had some form of chronic pain. An estimated 8% of U.S. adults met the criteria according to that survey for the high impact chronic pain. So, pretty much, we have a couple hundred people in this seminar this evening, and estimated by these accounts, 16 people, maybe more, depending on where we're on the sample, just looking at larger numbers, are suffering from high impact chronic pain to the point where their daily routine is significantly altered and they're having debilitating symptoms. If we look at how low back pain specifically impacts us, there was a separate study that was published in 2009 that looked at Americans who experience low back pain in their lifetime. So, 15 to 20% of the population develop protracted back pain. 2 to 8% have chronic back pain, that pain lasting greater than 3 months. 3 to 4% of the population is temporarily disabled due to back pain. And then 1% of the working age population is disabled completely and permanently as a result of their low back pain. That goes to the estimated $500 billion of lost revenue or potential changes in terms of how we look at those numbers long term. Americans spend $50 billion a year on low back pain. It's the second leading lost work time, the third most reason to undergo a surgical procedure, and the fifth most frequent cause of hospitalization. There was a follow-up study that was literally just published 2 weeks ago in the journal Spine. So they had 2009 where they looked at kind of some initial data, and then 2020. So where is the money spent? The medical insurance claims data is a great place to look at the summary of that information. So they took all the outpatient claims from 2009 to 2016, and that was about 100 million individual patient and outpatient claims for patients who followed the following criteria. They didn't have any cancer history, they had no spinal surgical history, and they had no recent pregnancy, but they suffer from chronic back pain. So from that cohort, they were able to identify 56,000 patients who had had a 2-year history of back pain, non-specific, and had had 30 days of treatment in both the first and the second year identified. So of that, you're looking at 55,945 patients. So of that group, 36,729 had received a prescription pain medication, the opioid or non-opioid alike, 65.7%. 60% received physical therapy. 56.5% received opioid medication, so 31,000 of the approximately 56,000 individuals. 50% went to chiropractors, 38% received muscle relaxants, and 25.9% received steroid injections. So you have a large cohort, they're taking a large sample size, and they're looking at where was that money, that 50 billion on average spent. So I take a second and I pause on that. That's why I underlined it. Because this is what I was talking about in terms of watching how things changed. Those numbers now are very different in 2020 than where they were in 2009. Practically. But over that large group, that shows you that opioid prescription medications were a very significant portion of what was the expenditures related to chronic back pain in the U.S. during that time period. Now, if you look at short-term, severe acute pain, 7 to 14 days following an injury, following a surgery, obviously patients are going to need pain medications. That's the best use for them. That's the appropriate use for them. But there are risks with that. Overdose, death, addiction, tolerance, cognitive issues, balance issues, constipation, nausea. These are just a handful of the side effects that can go along with that particular class of medications. But there are now a great number of growing studies that have shown that opioids are not shown to improve chronic pain outcomes. That could be a separate talk unto itself. It's been studied by the Institute of Medicine. There's been a large multi-volume set of research papers that have actually been centered out of the Northwest. A gentleman named Roger Chow, who practices internal medicine but is also a researcher at OHSU, has been a figurehead, along with Richard Deos, another physician at OHSU, who have talked quite a bit about the battle between the treatments of chronic back pain and the use of opioids. So if we're talking about what are some of the steps that have taken place and what are some of the changes that have taken place, we have to go back to that 2009 year when we're looking at the numbers at kind of the height of when pain medication prescribing was at its peak. The World Health Organization had a survey that went out, and it was called the International Narcotics Control Board, and they published their data in 2010. That was based on 2009 numbers. They asked all the countries in the world who are basically reporting or keeping track of morphine consumption in their nation to submit their data to the United Nations for review. The United States represented of the total global population 5.1% of the people who were included in this study. Yet when the data came out, we as a country represented 56% of the global morphine consumption that was worldwide in that year. 5.1% of the population consumed 56% of the global morphine that was distributed and recorded in 2009. That's an astronomical figure. There's no right way to even wrap your head around that. But when you think about that, it just goes to show in terms of where we were as a society in terms of prescribing patterns. Now, I don't want to, make this entirely about all the things that have happened in terms of the opioid epidemic and the crisis that is gripped our country for a number of years. But I just do want to add a couple more slides before moving on. It is very easy sometimes to utilize medications such as pain medications as a first step. But this is where practice patterns have changed, and the pendulum is swinging in the other direction. Half of the U.S. counties had a decrease in the amount of opioids prescribed per person from 2010 to 2015. And that was a result of a very significant push by the Centers for Disease Control and the U.S. government generally to try to decrease the amount of prescribing patterns that were done. That carried down all the way from the federal level down to the state level. The graph on the left side of the screen talks about these waves in terms of where opioid-related overdose deaths took place. The purple line is the commonly prescribed opioids, but there's a pretty stark drop-off in terms of between 2016 and 2018. It was rising steadily for 15 years and then began to drop after that. There was a rise in heroin overdose deaths beginning in 2010, and then the impact of synthetic opioids and fentanyl being brought into the United States caused a tragic and ongoing tragic increase in the number of synthetic opioid overdose deaths. So what do things look like in our neck of the woods? So I went specifically into Clark County, Washington, to try to find out where our numbers look relative to the state of Washington. So the black line with the dots represents the state of Washington as a whole. The brown line represents Clark County. And over the last several years, there's been a steady drop in quarterly number in terms of rate of prescriptions as recorded by the Prescription Drug Monitoring Program. So this is a reflection of a lot of public health efforts to try to reduce the overall number of prescriptions that are being distributed from medical providers. Non-narcotic pain medications, non-steroidal anti-inflammatories, Tylenol, pain-relieving antidepressants, Cymbalta, amitriptyline, nortriptyline. These are all medications that are commonly used as part of the comprehensive approach to managing pain from a non-narcotic or non-opioid perspective. Topical local anesthetics, all these things are part of the clinical picture they're in. So my patients hear me say, we're doing this to facilitate your participation in rehabilitation. And getting everyone moving in that direction is part of the larger picture too. So first tier line, this is all the stuff that everyone should be looking at: physical therapy, stretching, exercise, acupuncture, your local massage and chiropractic providers, cognitive behavioral therapy, over-the-counter medications, TENS, biofeedback, low-dose prescription pain medications. They're on there. We talk a lot about trying to minimize that. People who have chronic pain, they do need medication. We're looking at trying to find the lowest effective dose for someone and trying to utilize an interdisciplinary perspective to try to help them achieve that through not only other medications, but spinal procedures as clinically indicated. The third tier is we go down in terms of looking at long-term narcotics, surgery. And then on here, that's your spinal cord stimulation, and we'll talk a little bit about shortly. What is pain generally? It's our body's natural response to harm or possible damage. Now, pain signals, they come into your brain where you're processing that pain. So pain is an experiential thing. That's why I started with pain is subjective. It's your response to whatever illness you're going through. It's your response to your injury or chemical changes within your body. You basically have a moment where you realize that something is not quite right. Now that travels along the nerves to the spinal cord and then up to the brain, where you begin to equate that with an alarm system internally in your body. Now, how do we go about understanding the different types of pain? It goes to looking at the spinal cord itself. Now, you have the sections of the cord which are divided into the cervical, thoracic, lumbar, and sacral segments. Each of those are responsible for a different territory. So neck and arm pain is up in the blue at the top. The torso is this orange section through the middle. Low back and leg pain is mostly the green nerves here with a few of the sacral segments as well. Each one has a different territory, and that is the region that is responsible for that collective pain experience. Now, this is a little bit more into the neuroanatomy of it, but it kind of goes in showing us how this pain gets processed. We have our spinal cord itself, which is divided into kind of ascending and descending information. The ascending information goes along the sensory nerve roots and the sensory pathway. And those here are on the posterior roots of the dorsal roots. And those nerve centers collect the information that your body is giving it, put it into the spinal cord, and send it upstream so that it can be processed by your brain. As you're looking at how those sensory processes work, there's also descending processes also telling us in terms of motor function and also how the brain is asking us to change our experience of pain. And that is an important way in which we're able to sometimes modulate or change our experience to pain. It's by information descending down from the brain to help us get through to or address whatever issue is going on. So again, these signals are going up, traveling up via the dorsal columns. So these last two areas right here are important for pain transmission. They're on the rear of the spine, and they represent the culmination of all the sensory neurons. Kind of as they go up, they gradually add on and then ascend up into the brain. So we have nociceptive pain. This is a medical term, basically means that it is a pain that is from a tissue injury. It could be from skin, soft tissue, bones, joints, whatever the case may be. You have neuropathic pain, which is an injury to the peripheral nerves of the central nervous system itself. They're different in terms of how they're experienced, and they're different in terms of how they're treated. So we have two different sides of the coin. We have neuropathic pain and then nociceptive pain. How is neuropathic pain different? So if we look at how this difference is, we're starting to parse out in terms of how we're treating different individual pain systems. It lasts longer than generally would be expected for recovery from a specific injury. So if the nerve is damaged, I often use this analogy in the office. If someone has a piece of paper and you take that piece of paper and you crumple it up into a ball, the surgeon comes in, for example, and sees that balled up piece of paper and then takes it and flattens it out, pushes it out, lays it out on the desktop and pushes all the different surfaces out of it. Well, it still looks like a piece of paper. It still can be used to write a message, but those creases are still there. Those changes have happened to that nerve. A lot of change in terms of how the structure of the nerve occurs. It's been successfully decompressed. It's been flattened out, proverbially, but how does that change what that nerve does and how it transmits? Pain can fluctuate with activity, but it's always present. A pain that's constant, variable in terms of how intense it is, but it's there. You didn't do anything, you weren't moving in a different way, but you still have a burning pain into your leg. That's how neuropathic pain is different. It's dependent on really very little things that are in your individual control. This is how patients experientially sometimes feel neuropathic pain, burning pain, electrical symptoms, numbness, tingling, sharp pricks, pinching, hot pain, or cold. And if you look at it, if it becomes longer than 3 months, then it's now set into that chronic neuropathic pain scenario. And those are the ones that at times can become more difficult to manage. Now, this dermatome map, if any of you guys have seen me in the office, this is something that I use all the time. It's a picture that reflects all of the different nerves, kind of akin to that picture I showed you of the spinal column, and where patients feel pain related to that. The dermatome map is a key tool that we use when we're trying to localize chronic neuropathic pain. So someone will come into the office and say, I hurt in my buttocks. Then, doc, it starts to go over towards the front of my thigh. So it's like my buttocks, then it's the front of my thigh, and then next you know, it's the inside of my left foot. And I'm, oh, well, that makes perfect sense. And I show them that, I say, it's your polka dot stripe. And they're like, it's my L4. So that is where we start to take neuroanatomy and make it understandable to what someone is going through. Pain specifically down the back of the leg. You know, you're catching a sacral nerve root. And so each nerve has a different pathway. Same thing into the arms and the upper extremities, as you can see here. So when you're understanding chronic neuropathic pain, you're understanding that you're trying to find the location of that individual segment so that you can address it appropriately. So thinking points during this discussion: is your pain primarily constantly on or off? Is it only with activity? Is it positional? Have you been living with this for greater than 3 to 6 months? And when you're having a bad day, what are your pain levels? Failed back surgery syndrome or post-laminectomy syndrome, sciatica or shooting pain down the leg, complex regional pain syndrome. That's a unique condition I'll talk about in a second. If you're an amputee and you have phantom pain or residual limb or stump pain, spinal joint pain, disc pain, knee pain, hip pain, peripheral neuropathy, persistent pain after surgery that's greater than 6 months in duration. All these things are of interest in terms of trying to figure out what modality is most appropriate. Peripheral neuropathies, those are the end nerve endings, the ones that are down in the tips of the toes or the fingers. It can be related to trauma, crush injuries very commonly. If you look at it, infection, metabolic disease, specifically diabetic peripheral neuropathy is the most common of that, but it's also seen in patients who have hypothyroidism or have nutritional deficiencies, toxins, after chemotherapy. A lot of things can contribute towards peripheral neuropathy. Most often it occurs in the feet, and it's a stabbing, burning, tingling pain. Or it could be just numbness, frank numbness without pain itself. Complex pain syndrome or CRPS, this is a unique condition. This is one of those ones that most of the time, if you're talking to friends and family, you may never encounter this. It's a rare condition that in pain management circles, you'll see it when someone has an injury, or sometimes even doesn't have a significant injury, but we often see it with ankle fractures, wrist fractures, or traumas to the upper extremity, where after that trauma, your body generally goes about its normal healing process. And through that normal healing process, you're left with some pain. I can recall someone who I just saw a matter of days ago in the office who had an injury, ultimately had surgery, but was left with a rather significant amount of hypersensitivity, all diffusely through the right upper extremity. Point where light touching became painful. The wind blowing against your arm becomes painful. Different temperature changes become painful. It can be associated with hypersensitivity to touch all the time, changes in skin color. Your skin can be very hot or very cold inappropriately, and then you try to figure out, well, what can you do to try to manage that? These are common interventional procedures. These are things that I do every day in my practice: epidural steroid injections, medial branch blocks, which are designed to help with pain in the back, a radio frequency ablation procedure, SI joint treatments, facet treatments. There are lots of injections that are readily available to try to aid patients who have pain in their spine, nociceptive type pain or the mechanical type pain in their back. When you're looking at elective spine surgery, I just put this in there because I work in the surgical practice. Although I practice non-surgical medicine, I talk to patients primarily about when is it a good time to have surgery? When is it time to look at this? And it's clearly when you have something on pathology that's there on diagnostic imaging, the surgeon can potentially help you with, and that matches up and explains your pain. You failed other conservative treatments, or if it's more emergent, there's something that needs to be immediately addressed. The surgeon offers you surgery, and you're ready, and you desire surgery because you're ready to have that addressed from an operative standpoint. Those are all things that lead to good outcomes in terms of surgical care. We have patients who have done medicines, PT, injections, and their quality of life isn't there. They have chronic nerve pain, and they're not a surgical candidate. What else is there? Neurostimulation therapy, a non-opioid alternative for a variety of chronic neuropathic symptoms and neuropathic pain conditions, is neurostimulation therapy. This uses electrical stimulation to block pain signals. Now, I talk to patients about this oftentimes when we're really looking at a scenario where someone has a chronic scenario, they've got their pain condition, they've tried all the different things, or maybe they're using pain medications on a chronic basis. They're not comfortable with that. They want to change the trajectory of that. So this is the referral when we're looking and saying, hey, maybe we have something that can help you. And this is an evidence-based, well-established indications, and there are new options emerging that are really exciting. And that's one of the things that allows us to begin to offer neurostimulation therapy to a variety of patients. Now, it's not a cure. There's no long-term guarantees with anything. And as I talk a little bit more about that, you'll begin to see how that fits into the picture. But it is a treatment designed to help patients move forward. And the one thing, and this is the first time we talk about this, it is a medical device. Medical devices are a tool that we utilize to place in a patient to help that pain signal at the level of the spinal column. So when we're trying to figure out, is this appropriate for you? We tell patients up front, we're talking about something that would be a part of you for essentially for the rest of your life. It requires that level of patient coordination and care to understand the next steps. We have talked quite a bit about trying to basically look at pain and function and quality of life. So what is a trial? And this is something when we talked about, this is the most unique thing that neurostimulation as a treatment option for chronic neuropathic pain. There's an opportunity for our patients to try for a 5 to 7 day period what it would be like to have a device and get as much of a clinical representation of what a permanent system would feel like in terms of their pain and quality of life. So these are fluoroscopic images that are taken to show you guys how a system is placed. I'll have a video representation of this in a second so that you can see a graphic of it. But a lead is placed essentially just like an epidural needle would be down into the epidural cavity. Those leads are then threaded up into the epidural space and right into the region around the spinal column. Pain signals are traveling up from those neurons that we talked about in the spinal cord model, and they're going into the thoracic spine. After all the nerves that have come through the legs, they come together in the spinal cord into an area that's about the width of my pinky. Now, a neurostimulation option will deliver a signal to that area of the spinal cord and those dorsal columns we talked about before, and it meets it at the pass. It blocks it and replaces it with something that is not noxious. So we're taking a painful stimulus and replacing it with something that you don't feel. Brief video, let's see if we can get this to fire up here.
At the start of the procedure, you will be positioned on the operating room table. Once you are comfortable, the doctor will place thin wires, called leads, into the epidural space. The leads are connected to a small external battery to provide the energy to generate pulses, which work to interrupt your pain signals as they travel from the spinal cord to the brain. During the evaluation, the battery will be worn outside of the body, typically on your lower back. At the end of the procedure, you will be taken to a recovery room to rest. While you may be experiencing some temporary minor discomfort from the procedure, you will want to focus on how the therapy is managing your chronic pain. At the end of the evaluation, the leads will be gently removed during a check-in visit at your doctor's office.
It's a very short period of time, but in that 5 to 7 days, you can get a very keen idea of if something like that is going to help your neuropathic pain. On the whole, we're looking at the ability to do things to get functional improvements and reducing the need for pain medication. That is kind of the crux of what we're talking about in terms of looking at the global picture of trying to find therapeutic alternatives for patients who have suffered from pain for many years and who have no real suitable way to manage it. So here's a couple quick cases, and then we're going to move into our Q&A session. So this was a 70-year-old patient and multiple spinal degenerative changes. He had a surgery to take a small section of disc out at between L2 and L4. And then what you can't see in this picture because of the cut on the MRI, but he's actually fused as well because at the bottom of his spine is shifted. So there was no surgical indication left. They've already done a discectomy, a partial discectomy rather. They've already done a fusion. he's got some persistent neuropathic pain, and they're trying to figure out, what we can do. So we do an epidural steroid injection that didn't help. Ultimately, this patient got a spinal cord stimulator. And in doing so, that was placed in the thoracic spine above the areas in the lumbar spine where all of the stenosis was. You go higher into the thoracic spine to block that signal. Now, this is the first image that I have of a what's called a paddle lead. This image right here. This is X-ray of that same patient, where you can see in the thoracic spine there is something called a paddle, which is a permanent system. Now, this second case is an interesting case. This is a CRPS, a real patient with this. This patient was came to see me back in 2015. She had a proximal right upper extremity injury, and ultimately had the shoulder repaired, but had all of the tells and the hallmarks of CRPS: swelling, tenderness, pain. And this was the photograph of her in our first visit to the office. So eventually, through the process of going through and doing treatments, we got a spinal cord stimulator in place for her. And this was a unique case because it was placed actually in the cervical spine. That doesn't happen very often, but when it does have upper extremity symptoms, they can be placed there in appropriate patients. So 3 months after implant, on April 6th, she came back, and we had done the trial. The trial was great, but looking at her arm and the clinical improvement that she showed in her arm several months after her permanent system was in place, she was functionally able to use her arm. She was ready to take on the world, so to speak. Only residual thing she had was some small skin lesions, which were gradually going away, but she had suffered from those for a number of years. And it was really quite a successful venture. Now, this was just published in June of this year in Neuromodulation. This was a multi-center trial that looked at just under 300 patients at 22 different medical centers who had received spinal cord stimulation and followed their psychosocial functioning, followed their quality of life measures, followed their pain medication, and published the data. Improvements in pain, physical and mental and emotional functioning were observed from baseline to 6 and in 12 months follow-up. 52% of the patients taking opioids at baseline decreased their dose on average by 26%. 4% stayed at the same level, and 19% stopped taking any opioids whatsoever. So this was our first glimpse in terms of really looking at outcomes as it related to patients who wanted to see function. And in that same journal article, I won't present that data here, but they went into great detail about the functional measures and seeing clinical improvements there. So if you have a neuropathic pain and it's been present for greater than 6 months, you have persistent pain, doesn't go away, it's not positional, and you tried a lot of conservative therapy, and the surgeon has seen you and said, there's no specific decompression or something along those lines for our spine patients, then you should consider neurostimulation. Looking forward to continuing and talking to people about what options are available to them and what we can do to help you, not only through your journey, also improve your general quality of life. So we talked about these common applications for neurostimulation. Those are just a list there too. So if any of these, looking at failed back, chronic sciatica, pain after orthopedic surgery. I work in orthopedic practice. We see that too as well at times after you've had your hip or your knee replaced or you've had ankle surgery and it still hurts and you still have nerve pain. That would be something that, perhaps this would be a viable option for you as well. So this is covered by most carriers, but that's not why we're here tonight. But I just wanted to throw some things up there. If you saw your plan up there, then that's great. If you don't, then we'll work hard with you on trying to figure out if that would be a viable option for you. So right before we go into Q&A, I just want to reiterate how much John appreciates our patients. We're big into patient education. I know in my appointments, I really emphasize that. I want to take the mystery out of neuroanatomy, take the mystery out of your surgery, and really help patients understand where their experience fits into the realm of medical care. We'll work with the insurers. We'll work on all the different aspects of providing care for you moving forward. Trying to communicate with our referral sources is important to us. Providing feedback, we're always looking for ways to improve ourselves too. So thank you for listening. We're going to open up our Q&A. We've got one more virtual questionnaire. Let me forget. Yes, so I'm going to set this one up here, and then once we go into our virtual questionnaire, we'll have a couple questions here for you guys to answer. They'll come up in the sidebar, and then we'll get some questions in there too as well. So question number one, and this is basically thinking about yourself. Is your pain constant 24 hours a day or intermittent, i.e. positional, just when you're standing or in a particular position as well? So that's something to think about in terms of how that fits. How long has your pain been present? Are you into that chronic group, or are you in one of our patient groups who had pain greater than 5 years, greater than 10 years? And where is your primary area of pain? Legs and feet, neck, arms, hands, pelvis, or elsewhere? When you're having that bad day, how intense does the pain get on the scale of 1 to 10? It's that 5, 6, 7, 8 to 9. Are you at the 10 or 10? How are we in terms of that severity? That goes to that higher threshold question that we asked earlier. All right. So we've got some answers kind of coming in here too. So you still have time. There's no worries there. And take your time and answer those questions as you see fit. Have you ever had surgery related to this pain? Yes or no? So our answers are still coming in, so we'll give you guys a little bit more time.
Thank you, Dr. McGehee, for a wonderful talk. Are you ready for some questions?
I think so. Thank you, Kathy.
Okay. Right. Our first question is from Joanne. She's asking, what are the possible side effects of having a spine stimulator put in? Okay.
So in terms of side effects from the procedural side of things, is probably the best way to address that. Like any time that you have a procedure done, there are some inherent risks, and this is on part of the informed consent conversation. You undergo a procedure to have a trial, and then if you have a permanent device, you undergo a short surgical procedure to put a permanent one in place. So anytime you go through the skin, there's a risk of bleeding or infection or complications related to that. But in terms of side effects from the device itself, really aren't a terrible amount of things that are specifically placing you at risk for any side effects from the device itself. I have really never seen any significant allergies related to the components of the device, and I haven't seen anyone have any issues later. There are questions about MRI compatibility. That's a longer conversation, but you still can get a MRI. There has to be a couple of checks and balances that are made on the device so that MRIs can be performed, but that is something that has been cleared by the FDA. Yeah, another one for me, Kathy?
Yes, I do. From Glenn. Glenn is wondering, is it possible that there would be a rejection of the paddle?
A rejection of the paddle. So in terms of the paddle itself, the materials that are used in the paddle are the same medical grade materials that are used by spine surgeons for other types of devices. So it would be very unusual to have your body reject the materials that are utilized in the paddle. They are primarily made of the same materials that would also be used during the trial itself, but on a different scale. So that's the body's first exposure to that same collection of materials. And again, in the many years that I've been looking at at patients, working with patients, and being involved with implantations, I have not seen anyone have a frank rejection of the paddle itself.
Okay, next question is from Nikki. If you have cervical dystonia, would you still be a candidate?
So that's an interesting question, because cervical dystonia, as it relates to the etiology of the device, if there is a underlying separate cervical spine pathology that's not the dystonia primarily, then we would have to look at the entire clinical picture. It would not interfere with the placement of a device, because the dystonia primarily impacts postural movements from the head, neck, and the musculature of the paraspinals and the upper shoulder stabilizers. But that is an interesting question. We would have to look at what would be the indication for it per se, because cervical dystonia as a whole, being a neuromuscular question, is a little bit of a different indication in terms of the technology.
Thank you. I have another question from Barbara. Can the neurostimulation be done instead of a laminectomy?
Okay, so that goes to the question about whether or not you've been evaluated by your surgeon, and your surgeon is like, okay, you can have a surgery or not. Now, this question came up very recently in office, because we had a patient who was kind of on the younger side and had terrible neuropathic pain, but not a home run surgical candidate, because they didn't find that they weren't 100% certain that individual laminectomy would resolve all of their neuropathic pain. So that would be somebody that would be a great candidate for a trial, because the laminectomy, if they're doing the laminectomy specifically to decompress one area, and there's always a possibility, that's where the term post-laminectomy syndrome comes into play, that after you have that laminectomy, you continue to have persistent neuropathic pain. So provided that your spine is stable and there's no relative risk for you from an instability standpoint, then I think a trial would be very appropriate for somebody. But I would have to do that in conversation with the surgeon as well, to make sure that they were in agreement with that potential plan.
Thank you.
All right, what's next?
There's another question for you, Matt.
Okay.
A situation where a spine stimulator is more preferable than spine surgery.
I'm sorry, could you repeat the middle part of that? Is more what?
Is more preferable. So a situation where a spine stimulator is more preferable than spine surgery.
So I would say oftentimes there are patients for whom the relative risk of surgery exceeds a potential benefit, or they have multi-level degenerative changes in their spine, similar to the first case example that I gave you, and they have had a surgery. And it's like, well, yes, we could further decompress that spine, or we could go in and take your fusion from L2334 and add L5. Well, that's not always the best choice, because oftentimes my neurosurgical colleagues will very clearly say to me, they'll say, hey, I am at a spot where I don't think that surgery is the best option. That's why I included that slide as it relates to what makes a good surgical outcome, because there's always the back and forth with the surgeon as to what is appropriate and what is the next step. And if the next step entails looking at that relative risk versus the potential benefit, and they don't necessarily match up, then that's someone for whom neurostimulation may be a better option. And that's a lot of the neurosurgical referrals that I get are people who have had those neurosurgical consultations and have had those tough conversations, because neurosurgery isn't necessarily the right step for everyone at any given time. But I will tell you, we are always looking to stay on the cutting edge. And that's one of the reasons why we'll continue to have these talks. We'll continue to bring information to our patient base and to anyone else who is interested in. I want to thank all of you guys for tuning in. I know I didn't get a chance to answer all of your questions online. Overall, again, I want to thank all of you for coming online with me this evening and really getting a chance to get some information about historical trends, get some information about epidemiology, and learn a little bit about neurostimulation and whether or not something that is designed to address chronic neuropathic pain is appropriate for you as a patient. So thank you all. Have a good evening. I appreciate your time. Good night.